Welcome back to the Genius PT project. This is the second project that we're working on. Let's talk a little bit about this podcast and what we're hoping to accomplish. We want to really have real conversations about difficult subjects in PT practice to get to the heart of what is important in our practice, and namely integrating our skills. So for those of us who enjoy well-being in life and success in PT, the key ingredient is being able to integrate body and mind, bio and psychosocial, or the yin, which is being, and the yang, which is doing. In healthcare, we are drowning in information yet starving for knowledge. This podcast is a call to action. Collectively, we need to reframe our treatment of persistent musculoskeletal pain by looking at the whole person as they present to our office within a biopsychosocial framework. We're thrilled that you're going to join us as we collectively step into our future as a profession by making the complex simpler. Not simple, but simpler. Each project is a 3-month journey. This is the first session of Project 2. And the title of Project 2 is Serenity Amongst the Pushback, the challenge of changing how we treat pain. Susan Clinton and I will be doing this first session together, just looking at some of the research and theory underpinning change and the difficulties we experience in changing in PT practice. And then at the end, Susan will introduce Corey Blickenstaff, who is going to join us on month 2 and month 3 of this project. We're thrilled to have Corey and his expertise to help challenge us as we continue to grow in this area. So what do we know about change? Well, change is hard. What we all share in common is that most of us resist change. The status quo is definitely more comfortable for us than change.
And I think one of the things that's interesting about change is everybody knows we need it. We're all resistant to it. And the reason that we're so resistant to it is the way to change is we have to move to the edge of our comfort zone.
Right.
And sometimes to the other side of our comfort zone. And that's where the real struggle comes in, I think.
Yeah, agreed. You know, we are all so different. If I pull a class of 45 physios that I'm teaching, every single one of us will actually treat or approach a patient in a different way. We take our own unique skills and personality to that interaction, right? And so we get comfortable with what we're doing. Sometimes it's just easy to stay with what we're doing. And so what we really need to do, though, is to look critically at the research and the evidence and say, are we really practicing best evidence, right? Best evidence practice. Mm-hmm. And for most of us, we all need to challenge ourselves with that. And it's difficult, no question about it. So let's talk a little bit more about what we can do in the face of change. So we actually decided to really take a look at the Serenity Prayer, right? And so this is just a highlighted sort of the first part of the Serenity Prayer. And there's really 5 truths. So the Huffington Post in a blog in December 06, 2017, really looked specifically at the Serenity Prayer and tried to break it down. And I'm going to highlight a few things that they talked about. So again, for those of you who aren't watching the screen at this point and are listening maybe in your car or while you're going for a walk, the Serenity Prayer is, God, grant me the serenity to accept the things I cannot change, the courage to change the things that I can, and the wisdom to know the difference. So if we're looking at change in our practice, what we want to really recognize is that acceptance is not laziness, right? It means that we don't devote inordinate amounts of energy to changing things we can't change. Mm-hmm. We make a choice to let go and be more mindful. And I think, Susan, one of the things that I think about is one of the most dominant things that we can't change is really the person or the patient's character who's in front of us, right? They're going to bring, research shows that the outcome is going to be based on 40% of what they bring into the therapy room, mm-hmm. which we can't change. So there's acceptance. Right?
We're not part of that piece of them, but we can discover that. So accepting is discovering, I think, and not really trying to force our will upon others.
Right. And as we discover, it really means an open-ended conversation, right? And
Mm-hmm.
it really means that they are the expert on themselves, right? And we really need to take that time to listen. And I think that's one of our first challenges often in the therapy room. Certainly when I was trained in the McKenzie method, it was more about asking very pointed questions, right? Not, you wanted yes, no questions. You did not want open-ended questions because you were the expert and you were going to, do the assessment and you would tell them what was wrong. But especially when we think about a biopsychosocial perspective, they are the expert. We have to give them time to tell their story. We talked about that in the last project a little bit as well, didn't we?
We did very much, and that's part of the one of the foundations of setting the therapeutic alliance that we talked about in project number 1. And I think that's also the idea or the beginning of courage that you talk about in the second part of the Serenity Prayer. Having the courage to be different and look at things differently, and actually having the courage to give the reins of control back to the patient rather than holding tightly to them in our own hands.
Right.
It's hard.
Yeah, I would agree. I think courage, to me, that starts with we need to have the courage to first change ourselves,
Mm-hmm.
right? We often want to hop in and change other people and we want to change our patient, but, courage really means that if everything else is going to be equal, would we choose to start with trying to change ourselves? And I think the answer to that should be yes, because that's who we have the most control over, really.
Exactly. Exactly. My journey is my journey. Your journey is your journey. There are times when we walk side by side with each other on this journey.
All right.
And there are times when you are doing other things on your journey and I'm doing other things on mine. And we come back and we're able to share the differences of who we are, but have the courage to really look and see, wow, what is she doing that I haven't really thought about yet? And what am I doing that she hasn't really thought about yet? And that's just the journey of two colleagues.
Right.
So when we think about, the so-called medical model where you've got the expert and the patient, and this is what you do, and this is how you do it, and this is the way you do it, it does take courage to think, wow, what I really need to do is let the patient tell me where they are, where they're going, what their barriers are, what's happening, and how they can, what's going to actually strum their central nervous system.
Mm-hmm. Which leads us perfectly into this next slide where we're really talking about, so this concept of othering actually was a concept that I just have read recently about on Bronnie Thompson's website. And so I've again put the reference there. But sometimes what we need to understand is that some of the pushback to change might actually come from our patients, right? I think that's often where we struggle going into a biopsychosocial perspective is we're afraid of pushback from our patients. But I think part of that is because we set ourselves apart from our patient, right? So the definition of othering is that we identify positive characteristics within ourselves while at the same time noticing the absence of these positive characteristics in other people. Right? And so if someone in front of us is seeking our assistance for a persistent pain problem, one of the things that we might start to do is say, well, I've got resilience. I'm resilient. Why is this person not resilient? What is it about their story that has brought them into this office? And yet one of the things that I have found very interesting is when we have done research over the last couple of years and have used physiotherapists who come to our courses as part of our research subjects, when we're actually looking for subjects who have persistent pain, in the physiotherapy courses, I would say that about 50 to 75% of the therapists will raise their hands and say they struggle with persistent pain. So somehow we have to get over this sort of othering piece where we distance ourselves from our patient and find the place where we can actually relate to them. Right. And so the only way to do that really is to provide a safe and welcoming opportunity for the patient to tell us their story so that we can relate to their story. And if we're really honest with ourselves, relate to some of the struggles that they have.
And I totally agree with that. It's difficult to sit with the client and really empathize. And I know we talked about that in our first project as well, empathy versus sympathy. Not sympathizing and feeling sorry for them, but really empathizing. And that means digging down where that courage comes in and really kind of going, wow, what am I like when I'm struggling? Where's my pushback when I'm struggling? Where's my barriers? Where are my obstacles that I have to overcome at times in my own life? Maybe with my own pain, maybe with my own story, maybe with my own illness that I've had, or sickness, or loss, or grief. And I think that when we do that, and we can actually bring ourselves to that vulnerable part, then we're able to really hear them a little bit in a much different, the perception is different, quite
Right.
different when we come from that point of view versus the top-down point of view.
Yeah. Yeah. So again, taking this type of approach is less about looking for what's wrong, what's the pathology, what's the bit and piece that doesn't work, versus what is the whole story here, and can I relate to that story, right? Empathy is, can I come alongside that person and say, wow, I understand what you're feeling because I've had similar types of experiences, maybe not that specific one, but you need to find something within yourself to relate to your patient. Right.
Mm-hmm.
And that will help us to ensure that this distancing that is very normal in the therapeutic relationship doesn't happen, this othering. So when we look more specifically at how do we change this sort of othering model that becomes very easy to kind of attend to in a physiotherapy session, Bronze in 2015 argues that charity, or kind of this reasonableness argument, which just means that the person who's in front of us is actually responding in a very reasonable, rational, coherent way. And we may not always be able to understand the underlying reasons, but we should be able to connect with this person and saying that, really their way of responding to this crisis is reasonable. Right? They did the best they could in the circumstances that they had. And, except for the grace of God, there go I might do the same thing in those same set of circumstances. Mm-hmm. Right? And if we have that kind of approach and really lack sort of a non-judgment, not lack non-judgment, you actually have a non-judgmental approach, then we are much more likely to get into that good therapeutic alliance that we talked about in our last project, right? And if we had that kind of approach, it would be really a cool sort of lens to look at patients who we might then label as, they're not very motivated, or there's secondary gain issues, or they're non-compliant. If we take this reasonableness argument and saying the way they're behaving is reasonable given the circumstances that they are in, then I think we're much more likely to develop less pushback in that scenario.
And I think when we were talking about the top-down versus side-by-side, in the therapeutic alliance, that when we give these kinds of labels like lacking motivation or seeking secondary gain, what we're not doing is really finding out what the story is behind what may be perceived as lacking motivation or non-compliant. Perhaps their pain is making it hard for them to be motivated to move. Maybe they're afraid. Right. And if we could get to the fear and find out what's going on, you can figure out that maybe that fear is really inhibiting their ability to do the things that they know that they probably need to do and or want to do, but can't get past. And so rather than labeling, I think it's better to, like you said earlier, Carolyn, really find out what their story is, mm-hmm. and try to get to a place where you can say in that same circumstance or in the circumstance very similar, how would I have reacted?
Right.
And oftentimes we find more similarities than we really do. We really find a lot more similarities as when we come up against things. I know that there are times when I've been sick and I feel like I should be well and should be able to do all the 100 things I was doing before I got sick, and and how frustrating that is, and and so when you can kind of tack back into that kind of thing, it really does change how you're actually communicating with that person.
Right. Yeah. It's very powerful for really
Mm-hmm.
developing that alliance, right? And so again, when we're looking at developing a reasonableness argument and really starting to understand that person as the other person, but really our similarities with that person, the only way to do that is to use a consistent framework. And so we've been talking about already in Project One, and that's really the theme of this whole podcast, is to move towards a more evidence-based biopsychosocial perspective. And again, we live very comfortably in the biosphere as physical therapists. We live less comfortably in the social and the psychological spheres of a person's life. And this is where change needs to occur. This is where we need to start challenging our own growth to say, how do I become more comfortable there? You know, it's interesting. I have a couple of good friends at this point who are occupational therapists, and they are much more comfortable in the psychosocial realm, but less comfortable in the bio realm. Can you imagine how powerful we could be as clinicians if we could blend those skills and not keep them so separate as we have historically, right? All right, so we talk about sort of pushback for change happening at the patient level, but a lot of pushback also comes from within ourselves, but also within our profession, right?
Right.
And so we develop a bit of this us versus them mentality. It could be us versus the patient. You know, we again are superior, we know, and they need our knowledge, our skills to fix them. But it also can be kind of these different sort of identities that we create for ourselves, or values that we have. You know, I'm a mechanical therapist, or I'm a manual therapist, I'm an orthopedic therapist, or I'm a pelvic health therapist. And it's, you know, I think one of the things we need to do in the Canadian Physiotherapy Association, and I think the APTA is the same, we have all these divisions, right? And I'm starting to
Academy.
say,
Right.
united we stand, divided we fail. We have to stop thinking about kind of pelvic health as part of the women's health movement, right? It's part of orthopedics. It's orthopedics in a cave. You know, how are we going to start to amalgamate these skills so that we're all comfortable talking about them and incorporating them into our practice?
Exactly. There's a big push, I know, in the pain world that everybody should be thinking along the same lines, and not, okay, well, that's pelvic pain, that's different than what I do. And actually, in the biopsychosocial world, it's really getting the patient's story and really trying to find out what are the similarities, what is it that needs to happen here, how can we, you know, work with them to begin to start to make the changes that they need to make. And then if we need extra help in maybe some knowledge areas, then we can get them to people who may have a little bit different knowledge area, but they're not hearing a different story.
Right.
So the patient would go in with the same expectation that this person's going to listen to my story now, but apply it more in maybe the pelvic health world rather than the cervical spine whiplash world.
Right.
Right?
Yeah. And so, you know, I think one of the things we need to start talking about too is just even within orthopedics. So I'm a credentialed McKenzie therapist. That's my sort of orthopedic framework background. Susan is a manual therapist, right? She's IFOMT. So what is the title in the States you use?
It's a fellow for the American Academy.
Right. So. Yeah, right. And so, you know, if we had the same patient, we would probably take very different orthopedic assessment and treatment tools to that patient. And that, I think, is a little less relevant than the actual bigger framework pictures that we're talking about. So we have all this information, and yet we have, you know, very little knowledge around how to put that information into frameworks that make sense across our skill sets, right? And so one of the frameworks, of course, one of the things that we should have in common are the biopsychosocial framework. We've already talked a little bit about that. The other thing that Susan and I should have in common, even though we might take very different orthopedic approaches, is that our goal should always be to create the, you know, sort of prognosis and assessment sort of approaches. We need to know, or we need to have pain education as the cornerstone of treating pain. We have level 1 evidence behind pain education. That should be the cornerstone for both of us. And we really should be helping our patients to build self-efficacy. Those are the things that we should have in common. And if we have those things in common, I think it matters less what other sort of skills we bring to the table, right? Because there's good research that shows that about 15% is the treatment technique we choose. I want to say 15% is placebo and expectation. And I want to say 30% is a therapeutic alliance, and 40% is the extra therapeutic kind of factors that you can't control, like the person sitting in front of you and their personality and their story.
And their story and where they're from and their support system and social determinants and all of those pieces as well. Right. But I love number 4 when we were talking about that, because I think people understand pain education. But I love number 4 because building self-efficacy is actually I used to say turning the locus of control over to the patient, but actually they have the control. I like to, after I started looking at these slides and we started thinking about this project, I really started thinking about my language, and maybe by me saying turning the locus of control over is like, that's a little top-down-ish. And what I'd like to do when I think about building self-efficacy is help them bump up the volume on the things they know they can do. Right. They know what's wrong. They really do. They know how they got there. They can tell you that story. And they know a lot. I think everybody knows at least one step or something that they should be able to do to begin to change that story. And I like thinking about bumping up the volume on that.
Yeah, it's great.
Really saying you do know this. You're there. I'm just gonna help you see it a little differently.
Right.
But
yeah.
Rather than turning the locus of control back over.
Yes.
Like,
exactly.
That means you didn't have it for a while. That's not right. So
no, they're still in charge, aren't they?
So I'm still learning.
yeah, we always are. Okay, so let's look at those 4 things. So first of all, before we go any further, I think we need to just take a step back and just remember that humans are resilient, right? We are not fragile. And so I think it's been easy in the biomedical framework to create sort of a fragile model around this is broken, this is dysfunctional, this is out of place, this is, whatever language we happen to use, the disc is bulged, all of those pieces. We have to really be careful that we don't have the patient over-identify with the broken pieces, because are they really broken? They're healed, right? Things are tight, things are weak, or things have become sensitized. Mm-hmm. And so if you're listening and not watching the PowerPoint, we have a picture up of a water tap that's been taped all up, right? And so water is one of the basic things that we need for survival. And we could argue that self-efficacy, again, teaching patients and encouraging them to take care of themselves is the most important thing that we can do for survival for our patients. So how do we do that? How do we accomplish that? Well, we're going to go back again to the biopsychosocial framework. So again, I'm not going to spend a lot of time on this slide, but I want to bring it up one more time. We need the courage to change the things that we can. And it takes so much courage to actually move away from the biomedical model and move into a biopsychosocial model. Right? It takes so much courage because, again, we're strong in the bio piece, and the psychosocial stuff scares the heck out of us.
It does.
Yeah.
It's scary to ask people what they truly believe is wrong.
Right.
But you need to ask the questions. You don't need to say a yes or no answer question, but really think in questions. If you start thinking in questions, that encourages them to begin to explore on a deeper level about what's actually going on with them, finding out what they really think, away from the surface piece that they're showing you, and just really trying to get an understanding of what they know about it.
Right.
Because many of these folks have really read and listened and paid attention. They're just not sure. They're drowning in information too, which is why I love that one slide about drowning in information. But where do we go? And being able to help them, wade through the information, to get to where, out of this information, what do you think really makes sense to you?
Yeah.
and begin to find out where they are. And then that's so much easier to kind of help them and work with them side by side to help them clear a path to go forward in the direction that they feel they need to go.
Yeah. I think it takes curiosity. I try and always say to my patients, I want you to be curious. When you've got pain, when you've got symptoms, start to ask why. Why do you think this is going on? But why in a biopsychosocial framework, right? Not why in a biomedical framework, because that's not going to give you a whole lot of answers.
Mm-hmm.
So the other thing, again, that even though we may have different sort of manual therapy skills or orthopedic skills that we take to our patients, one of the things that we need to do is our language should be consistent, right? Mm-hmm. We need to talk the same talk. We're not fragile. We're not dysfunctional. We're tight, weak, or sensitized. So being really clear about that. We need to stop being the threat that their nervous system may have to protect against. So our language can create a nocebo. Our biomedical diagnoses can create, again, more reason for their nervous system to become more upregulated. Then we haven't done our job.
Right. And I love this when you think about just using terms that are more placebo rather than nocebo. And I think that applies to body language as well. I think we really, it's symbolic where you sit with your clients. It's symbolic if you're sitting up high over them versus sitting maybe next to them. It's symbolic if you're pounding away on a computer rather than making eye contact and really mindfully listening. It's symbolic if your arms are crossed over your chest versus kind of a open seated posture, and paying attention to them. I think those things together work so much better that it just raises their acceptance level and it raises their ability to really, build their self-efficacy, just really bump up the volume on it.
Yeah, and to accept maybe a broader framework as well, because sometimes our fears and change are, well, my patient just wants me to do something to them. They want me to touch them. They want me to fix them. And so, but if we start sitting next to them and explaining that pain is a whole person event and that it's sensory and emotional, and we need to talk about all of those pieces, then they get that too. They understand that, but we have to be consistent in our talking and in our approach with them. We talked about that last project as well, but it might be worth going back and listening to that project if you haven't had a chance to do so. The other thing that we need to have in common and be really consistent about is education, right? And so I think that's one of our strongest suits as physiotherapists is that we educate our patients extensively in many different things. We know that pain education plays a significant role in persistent pain. But again, pain education doesn't look the same for every patient. It's answering their questions. It's making sense of their story, which means that you first have to take the time to really listen to their story. And then the last piece that we really talked about is self-efficacy. And so here's actually a meta-analysis that was done on self-efficacy. And what it really shows is that self-efficacy can play an essential role as a protective factor, as well as a mediator in the relationship between pain and disability in people suffering from chronic musculoskeletal pain. So in other words, we have to start paying attention to self-efficacy. When they have higher self-efficacy levels, it's associated with greater physical functioning, physical activity participation, which should be one of our number one goals as physical therapists, their health status, their work status, their satisfaction with their performance, and lower levels of pain intensity, disability, disease activity, and depressive symptoms, presence of tender points, fatigue, and presenteeism, right? And so, again, what we know from this meta-analysis is that the overall quality of the studies is still not great. Much more research needs to be done, but there's this obvious trend towards really paying attention to how much self-efficacy do our patients have. And then the question I have is, do we measure it? Are these things, so Susan talked earlier about fear, and we'll talk in a few minutes about catastrophization and some other factors, but self-efficacy is an important predictor of who's going to go on to have persistent pain. Do we take it into account? Do we measure it? And do we maybe consciously not do manual therapy on a patient with low self-efficacy? Because what are we going to do? We're going to create more dependence.
Right. And when you look at this article here, and I encourage everybody to go and take a look at it, it really is kind of, it magnifies the role of self-efficacy, because it really shows that one statement that Carolyn made, that it's more important than tender points and, you know, this movement pattern and these other things. This is the deal. We know that people who are higher in self-efficacy do better. And so how can we bump up the volume on self-efficacy on our people, and how do we measure it?
Mm-hmm, mm-hmm. So this is interesting. So we talk about all of these different factors that influence the pain experience. This was actually a research article from Men's Costa and their group in 2011, sorry about that. And what they showed in this particular research study is that in their study, they showed that actually low self-efficacy more strongly mediated who would go on from acute pain to persistent pain than fear. And we know fear and fear avoidance is a strong predictor. Mm-hmm. So again, you know what we have to remember is that every single person in pain is unique. They're like a snowflake, right? No two are the same. And so we can start to see these global trends, but I think even more important in persistent pain is to remember that our sample size is n equals 1. And we have to assess every single person in front of us to see which factors are playing a role in their presentation and how we can best address to help them gain control back over their lives again. Mm-hmm. So when we look at that, so again, if you're listening by audio and you're not watching this right now, there's just a chart on the screen that kind of looks at all the different characteristics that we commonly see in our offices, like just central sensitization generally. Do we measure that, for example, using the central sensitization inventory? Looking at catastrophization. Again, are we measuring that specifically using the pain catastrophizing scale? Self-efficacy, I don't know what you use, Susan, but I use the PSEQ2, which is the self-efficacy questionnaire that has been recalibrated from the PSEQ10 down to the PSEQ2. So it's just as valid and reliable, but actually just ask the patient 2 questions and you can get as much information from those 2 questions.
Yep, I use that one too.
So yeah. And so we can go through and on this chart, there's a, sensory motor smudging. We can use the Fremantle questionnaire, depression, anxiety, stress. We'll use the DAS-21, for example. Fear, we can use the Tampa scale of kinesiophobia. Injustice, blame, and shame, which are high sort of factors that play into persistent pain, but also persistent pelvic pain, using the injustice experience questionnaire. And if we use, sort of biological plausibility and starting to understand that some of our treatment strategies like CBT or body mapping exercises or gratitude training, for example, or pain education, some of them may be better suited to certain characteristics of pain, right? If someone has high catastrophization, one of the key things that we need to do with catastrophization is really get them to reconceptualize pain. They really need to understand pain in their pain system so that they can stop their catastrophization, right? Mm-hmm. Sometimes doing a body scan can be really helpful with high catastrophization because they've stopped paying attention to any other part of their body other than their sore part, right? If they have
I call that looking for something different.
Yeah.
Because they're only looking for the alarm or the alarm to go off, and they've forgotten everything else. They just haven't, it's all so focused on that. And just really trying to get them to understand that when you pay attention to something different, that can begin to start to change that output.
Right. So their hypervigilance goes down, which is one of the subsets of catastrophization, right? If they're depressed, perhaps cardiovascular exercise, some CBT, or maybe some specific yoga may be a little bit more targeted to their depression. So I'm a big proponent, as you know, about measuring the different characteristics of the sensitized person that you have in front of you so that you can more accurately target those characteristics and more quickly change them. Because as I've gotten better at this in my own practice, Susan, I'd love to hear your words on that, but as I've gotten better at this in my own practice, my turnaround times are much quicker with patients. Patients, actually, their nervous systems are very adaptable if we create some effective targets for their nervous system. They change just as quickly as people in acute pain often, right?
Mm-hmm. They can. They certainly can.
They can.
Yeah. And that's the wonderful news about all of this. One of the things that I do in my practice is I will use these scales, but I take the titles off of them. So I kind of just have them there, and I have a set of questions, that I want you to just answer.
Yeah.
And that helps, because when people see things on top of like you hand them a questionnaire and it says fear avoidance belief questionnaire,
right,
they're on to you.
Yeah.
They're like, I played this game before. I know what you're trying to do. You're trying to tell me it's all in my head, and it's not all in my head. And, and so I try to take those words, those things off of the top. And sometimes I will just ask some of the questions myself and, get their answers on them, just to kind of get to, you can use those questions and these things if you're struggling finding the questions that you want. A lot of people will say, how do I do this? I don't even know where to start. And my answer is pull some of these questions off of these questionnaires and just start asking them.
Right.
And that'll start getting you somewhere. And then you can you get used to kind of how those questions are. And so then you can trust the scales a little bit better and know which ones, fill this one out for me, before you come back the next time. Take these questions home and ponder them and, give me your answers on this. This will help us kind of decide, make some choices about which direction and things like that. So that can work as well.
Yeah. I'm always a little bit hesitant in my own practice to pick and sort of cherry pick which questionnaires patients get, because I think that is probably reflective of my bias, sort of their presentation. So I try and be a little bit more global and just give them consistently to everybody. But if you do that, make sure that you then review each of the questionnaires with your patient, what their score means, why you ask them to fill it out, how that helps you understand what's going on with their nervous system, right? So we don't want to get too much into kind of cherry picking from that perspective. But yeah. All right. And so, we talked already or alluded a little bit to the fact that we're all snowflakes. Each one of us is individual. All of our patients are very individual. Their pain presentations are individual. And so what I think we can agree on from our varied sort of backgrounds and approaches is at least the frameworks that we use. So can we agree on using a biopsychosocial framework? Can we agree on using non-threatening language? Can we agree on creating high expectations for our patients, given that, if their nervous system is sensitized, given that what we now know about sensitive nervous systems, that there is, good potential for change. So can we use the placebo there? Can we really build their self-efficacy? And can we base that on good knowledge of the pain system and pain biology and what we understand? If we can at least agree on all of those basic framework items, then I think what we feed into that framework can be very individualized, and we can have consistent success if we do that. And so, who's responsible for change? We're talking about the difficulties with change, and the short answer is we all are. The short answer is that we are currently in North America in an opioid crisis. We are currently across the world in a crisis of chronic pain. And unless and it's easy for us sometimes to point the finger and say, well, that MRI shouldn't have been ordered by the physician because now they have this idea that they have degenerative changes. And so, or the physician prescribed opioids. And so, no, there's no finger pointing here, because collectively, we also have contributed to this problem of persistent pain by staying in a biomedical sort of approach. And so collectively, we need to look at, we are all responsible for changing.
And I would have to even add that if you don't know where to start with yourself. Always, be the change that you want to see. And because if you're not doing if you're not changing and working and working outside of your biases and changing the zones of how you're thinking, then no one else is going to around you. So start with yourself. It's the hardest one to do, but it also has the biggest punch,
Right.
Out there for sure.
And the very last slide, again, if you're listening to this, is a fully clothed woman in a bathtub in quite deep despair. And the stark reality of failing to change is the opioid crisis that we are currently living in, is the statistics on chronic pain. And the challenges that as a society we have created by staying in this biomedical model. Even though the evidence has been very clear over the last 10 or 15 years, change is difficult. And so we kind of stay with what we're comfortable, but that doesn't work, right? And we need to do better for ourselves, but also for our patients, for our communities, and for our healthcare, for the model of just the cost of doing business. We can't keep this up.
Okay. If you have any questions, you can join us on our website, which is www.thegeniusptproject.com. There's a section there to write in questions underneath each of the videos. We will have this posted. At the time that you see it, it'll be posted on the website, so we'll have that up and ready for you. And before we depart, I'd like to give you some information about our next speaker. Hang on just a second. Okay. So the person that we are going to be interviewing on part 2 is Corey Blinkenstaff. And Corey is the owner and operator of Forward Motion Physical Therapy, which provides the on-the-job site physical therapy clinics in the Vancouver, Washington area. He uses various movement and manual therapy approaches to empower people toward an autonomous state of health as it relates to movement. Corey also co-hosts, along with Sandy Hilton, the popular Pain, Science, and Sensibility podcast on the PT Podcast Network. Corey works with individuals who are dealing with movement-related problems such as pain or orthopedic injury, as well as employers who are struggling with the consequences of pain and injury on their workforce. Services are also provided to individuals hoping to improve performance at work, play, fitness, and who are looking for guidance on maintaining healthy movement through the lifespan. He has presented nationally on topics including application of graded exposure, graded activity, novel movements, movement variability, as well as application of care to the workplace. He has also authored a monograph on prevention strategies in the workplace through the American Physical Therapy Association. We look really forward to being able to do an interview with Corey in Part B. And Part C, as usual, you will be able to come on and join us and ask any questions of Corey that you wish, as well as we move through the idea of change and pushback against, the pushback and the serenity against the pushback as we grow to put that framework together that we should all be talking about.
Bye for now.
Okay, thank you very much, everybody.